What does it mean to be called crazy in a crazy world? Listen to Madness Radio, voices and visions from outside mental health. So thank you for joining us today on Madness Radio, Joanna Moncrieff.
Thank you. You're welcome.
Well, your book, The Myth of the Chemical Cure, A Critique of Psychiatric Drug Treatment, is really excellent, detailed a look from a medical perspective on how drugs work and the myths and misunderstandings about what psychiatric drugs are all about. And tell us about how you got interested in having a critical perspective on drugs and psychiatric treatments.
Well, when I started working in psychiatric hospitals as a junior doctor, what struck me immediately is how drugs were absolutely central to the process of treatment. Almost everyone who came in as an inpatient, and most people who were seen as outpatients, were on at least one sort of medication, and most people were on numerous different sorts of medication. And from my perspective, an awful lot of it didn't seem to be making that much difference. It seemed to cause a lot of secondary problems, and yet other doctors had a completely different perspective and seemed to think it was wonderful and people were getting better and because of the drugs. So I was aware that there were very different points of view about drug treatment early on, and that made me want to go and find out more about it.
And so what were some of the things that you've discovered and write about in your book?
Well, one of the things that interested me was the history of drug treatment. And when I looked back to the beginning part and the middle part of the 20th century, it was obvious that drug treatment, although it was used, didn't excite as much attention and interest as it does nowadays. And people didn't really think that drugs were curing people. They didn't think that drugs were altering the fundamental underlying problem. And then from the 1950s, that started to change, and psychiatrists started to believe that the drugs they had really were affecting the underlying disorder and helping to reverse it and to bring people back to normal. And yet, there wasn't really any evidence for that change in point of view. So that's what I've been looking at in my book and in other papers. I've been looking at the evidence base for how we view psychiatric drug treatments today and what it is, trying to understand what it is that they actually do to people.
Now, I guess the first drugs that were introduced sort of most famously was Thorazine, and it's an antipsychotic, a neuroleptic antipsychotic, and the real innovation with Thorazine was that essentially it's a tranquilizer that doesn't put people to sleep. That's essentially why it's so useful in psychiatry. Is that right?
That's right, and what's interesting is that the first people who used chlorpromazine in psychiatry recognized this and wrote about this very clearly. They wrote about how chlorpromazine creates this neurological syndrome, some of them called it. You know, they're almost talking about how chlorpromazine creates a neurological disease.
That's the medical term for...
Chlorpromazine is the generic name for Thorazine. It was marketed as Thorazine in the United States and Largactil in the UK.
Ah, okay.
So when chlorpromazine first came into use, the psychiatrists who were using it were very clear about what it was doing, and they described how it was producing this abnormal neurological syndrome that slowed people down and created this state of psychic indifference without just sedating people and sending people to sleep like the old sedatives had done. The barbiturates, which were used prior to Thorazine, had just made people very sleepy. So people thought it was a great breakthrough, but recognized that what it was doing was creating an abnormal neurological state. It wasn't just reversing an underlying disease. But then gradually that idea changed and people started to believe instead that it was an antipsychotic and that it was somehow reversing the processes that were leading to the psychotic symptoms.
they're basically still this tranquilizer, but it works more on the higher functions of the brain, and so people lose motivation. They become indifferent to what they're experiencing. I mean, I've been on antipsychotics. I was on Trilofan and Mellaril, which are some of the older drugs, and they were very much, I mean, I remember blacking out from when I was on Mellaril, just not having any consciousness at all. And then I remember just being very much like it was kind of like some kind of a vice, or some kind of like a cotton or wool was on my mind, just totally sluggish and just was groggy and could not. But, I was wandering around and sitting and watching television and sort of being there in the hospital.
Yes, that's a really good description. And they also seem to slow people down physically and cause physical restriction. They slow down movement. I mean, essentially, the older antipsychotic drugs cause a mild state of Parkinson's disease. We know that if you give high enough doses, they cause obvious Parkinson's disease-like symptoms. People get very stiff. And what I think is happening at lower doses is that they're causing milder symptoms of Parkinson's disease, which is a slowing up of movement, a feeling of restriction, both physical and mental.
Very much like a tightening or a gripping of the body, and you see people who are on high doses, they look, and that's, I think, where the term the Thorazine shuffle comes in, because you have this kind of like very stiff walk because you're no longer free. Your muscles have been tightened up. And when you say Parkinson's disease, tell us a little bit about that.
Yes, well, Parkinson's disease is a neurological disease which is caused by a deficit of dopamine in the brain. There's not enough. The brain isn't producing enough dopamine, and we need dopamine for movement and for thought. And so people with Parkinson's disease become stiff, and their movements slow up, and they lose their facial expression. And their thought processes slow up eventually as well. And the antipsychotics block dopamine production, and therefore they're inducing an artificial Parkinson's-type state.
And then when they became more widely used, that's when the idea of the dopamine hypothesis as causal for schizophrenia came in. Yes. Now,
that hypothesis followed from some experiments on haloperidol, and haloperidol is a very strong dopamine blocker. And when it was identified that haloperidol was working by blocking dopamine receptors, then people leapt to the conclusion that the underlying cause of schizophrenia must be overactivity of these dopamine receptors or the dopamine system. So there was an assumption that the drugs must be working by curing the underlying problem, whereas what I've been trying to say is that it's obvious that they produce this artificial state of, as you've described really well, this state of restriction.
And it sounds like previously to the introduction of the psychiatric drugs, there were much more psychological understandings of what schizophrenia is all about, and then the drugs sort of ushered in an era of seeing things strictly in terms of chemical imbalances and biological disorders of the brain and such.
Yes, I think prior to the 1950s, there was a social psychiatry movement. Psychoanalysis was very influential in the United States. But there's always been a tendency within psychiatry to want to find biological causes and biological explanations for mental disorders. So that's always been there, but it was given a really great boost by the introduction of these drugs, because psychiatry could then present itself as having medical treatments the same as the rest of medicine. It could present itself as doing the same sort of thing, giving people drug treatments to treat specific conditions, supposedly.
So when these neuroleptics were introduced, and then there was this theory that was developed that dopamine was the problem behind why people had schizophrenia, that became really widespread in psychiatry and kind of became the ruling theory about what schizophrenia is all about. Now, today, is that still believed, or because there's been a tremendous amount of research that's never been able to show that that's actually the case?
People in the psychiatric community, psychiatrists and researchers, again seem quite convinced that there is a dopamine abnormality underlying the symptoms of psychosis. Even though, as you say, there's an awful lot of negative evidence, the positive evidence is completely inconsistent, and even even evidence that's quoted in favour of it, like the idea that stimulants, people say that, we know that stimulant drugs like cocaine and amphetamine cause psychosis, and because they stimulate dopamine, therefore psychosis must be caused by dopamine. But in fact, when you look into this, stimulant drugs like amphetamines affect numerous neurotransmitter systems, numerous brain chemicals. It's not just dopamine they affect. And so we don't even know that stimulants-induced psychosis is attributable to dopamine, let alone other episodes of psychosis.
So essentially the idea that there's a biochemical imbalance behind schizophrenia really came looking backwards on saying, well, these drugs seem to be working, so therefore it must be the drug action dealing with the underlying disease. But in fact, that's not what's going on.
Yeah, that's exactly what happened. So the theory is already based on an assumption that if the drugs do something, they must be curing a disease. They must be working on the cause of the disease, the cause of the symptoms. And I often give, when I talk about different ways of understanding what psychiatric drugs do, I often give the example of alcohol and social anxiety. That we know that alcohol can be helpful for people with social anxiety, but that's not because they have an alcohol deficiency. That's because the state of intoxication that alcohol produces is characterized by a bit of social disinhibition, which can be useful if people are very socially anxious. But it doesn't say anything about the cause of the anxiety, the original cause of the anxiety.
Yeah, this is something that we talk about in the Harm Reduction Guide to Coming Off Psychiatric Drugs, and you discuss in detail in your book that actually this idea that there are recreational drugs on one hand and then they're way different, there are pharmaceutical psychiatric drugs on the other, and we actually don't even like to call those drugs, we call them medications, that the action is completely different. But what you're suggesting is that just like alcohol has a toxic effect, and so it causes chemical changes in your brain, gives you an intoxicated experience that for some people might be useful for them in, say, a social anxiety situation at a party or dealing with crowds or meeting people. The same kind of dynamic takes place with psychiatric drugs, that they change consciousness, they intoxicate you, they work in similar kinds of mechanisms of disrupting brain chemistry, and then the effects may or may not be useful based on the intoxication. Is that a fair way of kind of assessing this?
Absolutely. That's a very good way of putting it. I think that we should think of psychoactive drugs as including all the drugs we use in psychiatry and recreational drugs, and there's no fundamental distinction between them. What I often say, there's no fundamental distinction between the drugs we use in psychiatry, like antipsychotics and antidepressants, and the drugs that people take for recreational purposes, like alcohol, cannabis, stimulants, etc. What I often say, though, is that people take recreational drugs because they have nice effects, they make people feel good. Most psychiatric drugs don't make people feel good, they make people feel quite bad. But that doesn't mean that they're not having psychoactive effects. They're just they're producing a different sort of state, which most people don't like that much.
Yeah, and we also know that with the recreational drugs, a lot of times people are taking them for emotional, psychological, social coping. So they're kind of like they're medicating themselves or allowing themselves to be productive or effective. But the difference, of course, is that in psychiatry, you have this huge institutional authority machinery that's saying, wait a second here, there's this underlying disease and disorder, and the medications are treating it or dealing with it.
As you're saying, the thing that I think we're doing wrong at the moment is we're not understanding psychiatric drugs as drugs. We've got to understand them as drugs, as chemical substances that are alien to the body, that create an artificial state. It might be useful to take them, but whenever you take a drug of any sort, there are all sorts of dangers and hazards, and we need to treat them with that sort of, with respect, because we've just been obsessed with, do they alter the dopamine receptors, or do they, do antidepressants raise your serotonin levels, instead of looking at all the other things they're doing and what consequences all those effects have. We need to understand them, understand what sort of effects they have, in order to be able to use them wisely.
Do you think that's one of the reasons why the negative effects of these drugs is so underplayed and overlooked in psychiatry, and it's considered just a part of the cost of treating a disorder or treating a disease?
Yes, absolutely. So what's happened is that instead of seeing psychiatric drugs as drugs, they've become treatments. And by becoming treatments, psychiatrists are then able to focus on the supposed disease and the benefits of the treatment, and all the negative aspects of using a drug get put into the small print, get shoved aside and obscured. It should be more openly debated, and it should be more democratic. If we're going to control people's behaviour, and I think society does need to control some people's behaviour sometimes. So it needs to control the behaviour of some of the people that we diagnose currently as having psychiatric problems. But we need to do that honestly and openly to make sure that we do not overstep the boundaries, that we do not go too far. And the trouble is, if it's dressed up as medical treatment, there's nothing to stop you. There's nothing to stop the system from really heavily drugging people and controlling people in a very authoritarian way for a very long time. And that's what I think happens to some people in the psychiatric system.
Joanna Moncrieff, thank you for joining us today on Madness Radio.
Thanks very much, Will.